Hello, good evening, everyone. Sorry for keeping you waiting. Thank you for joining us today and welcome to our second session of the Gulf Diabetes Technology Network. I am Ayan Namir, the Gulf Diabetes Medical Science Liaison at Abbott Diabetes Care. Today, our second session at the Gulf Diabetes Technology Network. This program is sponsored by Abbott and endorsed by the Emirates Nursing Association. We're very happy to have you all with us today. In this session, we will explore how CGM technology can go beyond numbers, becoming a meaningful tool to drive awareness, motivation, and long-term lifestyle improvement for people living with diabetes. Before we just begin, I want to introduce today's speaker, Mr. Khaled Alsahly. Khaled holds a bachelor degree in clinical dietetics from San Francisco State University in California. He has over 4 years of experience as a clinical dietitian at the endocrine and diabetes unit at Jaber Al Ahmed Hospital, where he also leads the unit nutrition team. He has concluded several workshops on diabetes care and presented at Professional Conference of Alzheimer and Type 2 Diabetes. His passion for diabetes care is also personal. Having lived with type 1 diabetes from a young age, Khaled brings both scientific expertise and lived experience to help others balance nutrition, physical activity, and insulin management for better quality of life. Khaled, over to you.
Aya, for the great introduction, and I want to thank Abbott and the ENA and the DES for the great invite. It is an absolute pleasure to be among you today to talk about a topic that I am very passionate about. So today, of course, our topic is the role of CGM in supporting positive dietary and lifestyle changes. Yes, so we can first start by highlighting the most important aspects that we should focus on when we are dealing with diabetic patients. So the first one should definitely be focusing on HbA1c levels to improve overall glucose levels, be it HbA1c coming from serum values or an estimated HbA1c level. So by that we mean tight and long-term glucose control with less glucose variability. The second definitely should be to avoid hypoglycemia with our patients. So it should be a very strategic approach with insulin and diet to minimize hypoglycemia and have tight control, since hypoglycemia is definitely one of the most dangerous aspects when we are talking about diabetes, be it type 1 or type 2. And the third aspect is limiting glucose variability. As we all know, glucose variability is when we have ups and downs with our glucose readings. And this definitely has been proven to have a very negative effect on the nervous system, cardiovascular health, and can lead to neuropathy and other complications. Now, let's talk about Freestyle Libre as a behavioral change intervention. So when we're talking about sensors, we must compare it with glucometers to have a good contrast. When we are comparing both, there is a very clear contrast that having CGMs with type 1 and type 2, it can empower the patient and it can lower anxiety and having confusion and fear revolving around sleep, exercise, diet, work, and pretty much all aspects of daily life. So there is an empowering effect, there is a relaxing effect, and the other aspect is also by having live glucose readings throughout the day, patients can see patterns in their RBS values after eating or exercising. And by recognizing such patterns, they can definitely have positive biofeedback, and that can definitely have changes on behavior. As I have seen with many of my patients, if you can go on, please, go back, please. I have seen with many of my patients, people who go from glucometers to sensor experience very positive changes. So I highly recommend the change. Now, it is important to highlight that approximately the mean time a person with diabetes spends with their healthcare professional every year is around 3 hours. So that's including the dietitian, the doctor, the diabetes educator, the nurse. And after those 3 hours, there is 8,757 hours. And in those hours, the patient is just taking care of themselves. So that highlights the importance of having the right tools, such as the right amount of insulin and having good education around insulin, diet, and of course, CGMs. Since that has an effect on taking and adjusting medication, taking glucose measurements, having mindful food choices, and having regular exercises. So there are various barriers that prevent people with type 2 diabetes in making lifestyle behavior changes. One of them is definitely a very prominent one, which is having a lack of information. Some of them don't have good access to healthcare, or they don't have they cannot seek the right knowledge, and that has an effect. And of course, they do not see their condition as something serious, especially considering that type 2 has a lower risk of DKA, and the very complicated or the very negative complications come on later in life. So that makes them slack off and not take their condition seriously. Sometimes we see patients with CKD or heart disease or other health complications, and that can take away the focus away from diabetes. And also there is frustration from lack of success. So when they follow doctor's advice or dietitian's advice and they don't see good results, usually they just stop following advice, and maybe they will stop even going to the doctor's visit. The other one is they need drive to make change, so they don't have the drive to make changes to improve their health, and they're satisfied with their current behavior. So to them, it's not worth it to make the change. And of course, there are other external factors. We have a strong factor, which is family and friends and work, or it could be costs or cultural background, and sometimes physical limitations. Perfect. So now we have the COMBI framework of behavioral change. This is a psychological module that helps us as healthcare professionals to, first of all, identify what our patients require to make the change, and second, to get a better idea about our patients and what they need. So first of all, we have capability. So we have to ask, does the individual have the knowledge and skills to engage in the behavior? Sometimes we have limited capabilities in terms of education or comprehension. So we have to adapt and make compromises and changes for each patient. The second is motivation, like we mentioned earlier. Does the individual have the energy and drive to engage in the behavior, or are they just comfortable with where they're at? The last one is opportunity. So does the external factors that they have in their life support the change, or does it prevent them from changing? All these can be tweaked and played around to have the patient change their behavior depending on the healthcare professional and the tools. So now let's connect what we just talked about to glucose sensing technologies such as the Freestyle Libre. So its impact on Combi components. First of all, in terms of capability, by having access to personalized glucose data, including trends, the time and range, having arrows indicating whether the glucose will go up or down. All these things can have an impact and increase the capability. Understanding how food and exercise can impact glucose levels definitely can have a better effect. So this is our role as dietitians, of course. And motivation, definitely, it can increase motivation by increasing engagement and having biofeedback after doing different things such as exercise and trying different foods. And opportunity, this is actually one of the most important aspects. It helps us as healthcare professionals to help our patients in a better way. So this is a very important change. So adding to what I just said, that we can have attitude shifts from having CGMs by making the invisible visible with having more information and more data to work with, by enabling effective decision making, which is what we have with proper education by the HCP, plus the right tools, as I mentioned earlier. And then enhanced self-efficacy. Like we said, we have, first of all, lower anxiety. And second, we have more gratification by having the right or doing the right things. And then behavioral changes such as diet changes, exercise, and adjustment to medication, which can lower the probability of hyperglycemia and hypoglycemia. So now let's move into a very important part in diabetes care, which is nutrition. First of all, let's talk about carbohydrates, and it should always come first, whether by it's from a dietitian or any other healthcare professional, since it is the driving factor in hyperglycemia. It has the strongest effect, and there is a lot of misconceptions regarding carbohydrates. So first, let's talk about starchy foods. Of course, the examples are bread, rice, pasta, potatoes, any kind of breads, and then juices, and so on. It is the primary energy source, and one of the ways to control its or limit the hyperglycemia is by adding fiber, fat, and protein. There are also natural sugars, which are fruit, milk, yogurt, and also honey. In the clinic, in our work, we see a lot of misconception, especially with type 2 diabetes, where patients think that since the food is natural, then it's not gonna raise blood sugar levels. Same thing, as I said, we see patients mix up that since the food is healthy by having vitamins, minerals, antioxidants, then it shouldn't be bad for the diabetes aspect. But of course, it raises blood sugar levels. And then, of course, processed foods with added sugar, so sugary drinks, biscuits, cake, chocolate, they are the fastest in digestion, especially when they are in liquid form. So one of the negative things that we see in our work is people normally like to have their information simplified. Us as the professionals, we can complicate things, we can get into detail, but for people who just want a simpler, easier life, they like the info to be simple. The reason I say this is that people often mistake our advice as that they should stop having carbohydrates, they should stop bread, they should stop rice, and so on. and that can lead to hypoglycemia and other complications. So we have to be very clear that they can have all these kinds of foods, but there should be portion control, there should be carb counting, and that the smaller portions will not raise the glucose levels very quickly and too high. And then the large portions will, of course, raise it super quickly. So here on the left side, we have an example of one of the resources that I personally use in my clinic in Jabir Al-Ahmed Hospital. So this is a book from Carbs and Cals. It has examples of many different foods in different amounts with visuals and how much they would raise the blood glucose level. I highly recommend this as a resource to use with your own patients. So estimating carbohydrate portions. What we mean by this is what we commonly refer to as carb counting. There are many different methods, and sometimes people do this correctly, and sometimes people make mistakes. So let's go over this quickly. As I mentioned just now, there's some great books, such as Carbs and Cals. We actually use both books that are in this picture. We have websites that we can use as references. So one very good website with an accurate database is called Track, Track. I'm sorry, that's the application. The website is called Nutrition IX. So this is the first one. The second is called Carbs and Cals. They have their own website. And then there are multiple others where we can use them to help our patients calculate the carbs. One worthy mention is actually using ChatGPT, which some of you might not agree with. But I would say that if we have the right amount of food, people can use AI or ChatGPT accurately, and it can make life very easy for the diabetic patient. So now let's talk about glycemic index. Glycemic index is a wonderful tool that educational tool that we can use to simplify things to our patients. So basically, a lot of factors influence the glycemic index. We have the nutrition composition, which is, of course, how much carbs it has, how much fiber, protein, fat. All carbs raise the glycemic index, and the other ones lower the glycemic index. The other one is cooking method, but it doesn't have a strong effect. There is a very small effect. The ripeness of the fruit. So first of all, the ripeness can raise the the glycemic index. And then the second one is that if the fruit is in season, then it would have higher glucose content. And if it's off season or grown indoors, it would be less sweet. Also the processing, when food is too processed, it loses fiber. It can lose protein, or maybe protein was not added to it. So it can have very quick rises in RBS. And then lastly, the type of carbohydrates. So this is when we say that switching from white to brown, or white to multigrain, it has an influence. Other worthy mentions definitely should be that solid food is slower in digestion than fluid. So this is one of the reasons we say drinking your calories or drinking your sugar should be limited or avoided for some people, depending on the situation. Okay, so now let's talk about fat and protein. Fat and protein, as you can see on the graph, it can first slow down the digestion of the carbs. When you look at the blue line, this is a low-fat, low-protein option. So the glucose goes up very quickly, and then since the patient didn't take an accurate amount of insulin, it continues going up. And then the second one in red is high fat and high protein. So the insulin works quicker than the digestion of the body. So you can see that the RBS dropped down too quickly, and then the digestion kicked in, and then the glucose slowly, within a few hours, started going up. So what we get from this, that since digestion is slower, we have a different effect to glucose. A small portion of fat and a small portion of protein, especially in big amounts, they can convert into a small amount of carbs. It's not a notable amount, but it can be counted. And of course, we have insulin resistance and a typical glucose pattern. As I mentioned, the hours of digestion can be 4 to 5 hours. So we should definitely have an insulin change here. Usually we have a 60-40 split, which is when we take 60% of the insulin with the meal and then 40% of the insulin 1 hour and a half or 2 hours after the meal. And this can make us avoid what we are seeing in red. This is one of my favorite features on the Freestyle Libre app. So as you can see in the photo in the middle, at the bottom, we have a button where it says add note. We teach our patients to add a note for their food and their rapid acting insulin. So they are logging everything they're doing. By doing that, when we are looking at their data on their phone or on the AGP report, which we will see later on, we can see that it's a lot easier to understand the data, and it makes us make smarter and more accurate changes to the diet and medicinal plan. Okay, this is actually a personal favorite also of mine, since I am type 1 and a lot of my patients love this and use this on a daily basis. So for hypoglycemia, we have arrows that are pointing down but sideways, and then the second one is completely downwards. These indicate how fast the glucose is going. So if the glucose is 6 millimole per liter and the arrow is down but sideways, usually a good correction would be 4 to 5 grams of fast-acting carbs. So by that I mean it can be a teaspoon of sugar dissolved in water, or a teaspoon of honey dissolved in water, or just a teaspoon itself of honey, or a small piece of candy. For the second one, the 6 millimole with the arrow completely going down, it can be like we said earlier, a teaspoon up to two teaspoons of white sugar or honey, or maybe a sip of juice. For actual hypoglycemia, it is best to go with fluids. So we think of juice or soda, and it's half a glass or 150 milliliters. And that's a very good and efficient way of correcting, in opposed to eating chocolate or candy, which takes time to digest. So now let's talk about physical activity. So first of all, let's talk about aerobic exercise. By aerobic exercise, we mean walking, cycling, jogging, swimming. It can be brisk walking, which is when we are actually walking quickly, or it can be normal everyday walking. All of the activities I mentioned can lower glucose, especially if it's for long periods. The longer the period, the bigger the glycemic drop. So most of the time we have to make insulin changes. If there is active insulin in the body, we can add carbohydrates by eating something. If there isn't any active insulin, then it can be done if the RBS values are balanced. With resistance training, it's actually mixed, because With resistance is actually if the person has high insulin resistance, they can actually have hyperglycemia when they do resistance training. But after they stop and after the body relaxes and the heart rate slows down, they can have a very quick drop. So it varies from person to person. I have some patients who actually take insulin to lift weights. So it's very mixed. Both aerobic and resistance training can, in the long run, lower HbA1c and fasting glucose levels. So, of course, as benefits, for aerobic, it can improve cardiac health, it can boost immune system, reduce heart disease risk, and improve blood flow and have different effects like enhancing mood and improving insulin sensitivity, which is the most important one. For resistance exercises, of course, increase muscle mass and the long list of benefits. Most importantly, improves insulin sensitivity and enhance cardiovascular health. So, like we said, one of the best ways to lower glucose levels, and this is advice yeah, of course, we can cover more carb counting. Don't worry about it. So for hyperglycemia, uh, like we said, one very good way of correcting is just walking after meals. It can be done 10 to 20 minutes after the high carb meals, and this can actually reduce the need for insulin, which is a very good tool to teach our patients. Resistance training should be done at least 2 to 3 times per, and all these activities can lower weight in the long run and have a very good effect on RBS and HbA1c. Okay, next. So yeah, like we said, exercise can be a very good tool. One good way to avoid hypoglycemia, since a lot of our patients can be scared of exercising, is that if using insulin and the insulin is active right now, so it was taken within 2 hours of the start of the exercise, they can have, let's say, 10 to 20 grams of carbohydrates without taking insulin, or they can reduce the insulin they took for the meal if it's within the 2 hours. So it can be done both ways. And of course, they should monitor very closely. Normally, we go with checking the readings every 30 minutes of exercise so that we avoid strong fluctuations. So now let's talk about the daily graphs, so the AGP reports and the trends and all these great tools that can help us help our patients. First of all, I will give you an introduction to an AGP report. So here, as you can see, yeah, we have the legend at the bottom. So let's look at the bottom first. So for orange, we have high glucose. For red, we have the hypoglycemia. For the white circle with blue around it, it's the scans. So it's the manual scan done by the patient like this. And then for the apple, it's food that is logged. And for the insulin, it is insulin that is logged. And if we have the square, with the value inside it, then the value is the peak, which we will cover now. And sometimes we have a clock that indicates time change. So for the next one, okay, perfect. So this is the legend we explained. Yeah, perfect. So here's a second example, but for this one, we actually have more data because the person is using the sensor and also using the Freestyle Libre reader. which is something that a lot of my colleagues and myself, we recommend our teenagers and peds patients who can't take their phone to school, so they can use the glucometer instead. You can see the readings at the bottom, and then in the red color, of course, we have hypo during sleep, and then other trends that we will dive deep into in the next slides. Before covering the glycemic trends, we should definitely first talk about rapid-acting insulin, short-acting insulin, intermediate, and long-acting. And I can definitely say that GLP-1s will soon be among this list, although it's not an insulin, but it is a great tool and one to consider for our patients. So if you can go to the next slide, perfect. So I just want to highlight the two of the most common and most important ones. First, we have rapid-acting insulin. It is important for us and our patients to know that medicines such as Novorapid, Humalog, and Apidra, they take 10 to 15 minutes to work, and their peak, so their strongest effect is around 1 hour, and they stay active in the body for 2 to 3 hours. There can be some variability depending on insulin sensitivity and resistance and so on. For long-acting insulin, such as Lantus, Toujeo, or Tresiba, it can stay up to 24 hours, usually within the 15 and 16-hour range, and the onset is 2 to 4 hours. Perfect. So now we reach the point of talking about daily graphs. So this is the most important thing that we all should be comfortable to work with. So first, let's look at the axis. So we have the glucose and we have the time. In the green zone, this is the target range. So this is the range we want to stay in. By dropping below the green, we are in hypo. By going higher, we are in hyperglycemia. So in this example, the person took insulin shortly before eating, and they calculated carbs very accurately. And then insulin worked very well with the amount of carbs, so there was no mismatch, and it didn't drop. One good thing to point out here that the starting line, so before the peak, the starting line and the ending line is almost aligned. So that tells us that insulin is exactly matching with the food. A second example here. So we see that the patient took their insulin, and it took their insulin, and maybe there wasn't a long period of waiting before eating, but we see that one of the possibilities here is that the food was fatty or high in protein. So they had a drop, and then the body continued digesting, and then the glucose went up. So it balanced out on its own. So there was no need for correction. Okay, so on the right, we have the treatment considerations. So the insulin to carb dose, maybe it was aggressive. It's a possibility. The second one is maybe it was taken too early before the meal. Or yeah, there are a lot of variables here, but most likely I think it's food. Perfect. And here we have the food, and then the insulin was taken after. So it was maybe around 30 minutes up to 1 hour after eating. They took the insulin. And then after taking the insulin, it took them some time to reach the peak, and then the insulin dropped. So of course, this is a very common mistake. And if we continue the pattern, maybe they overly corrected the hypo. So it wasn't the amounts that we discussed earlier. So they had a hyperglycemia episode again. Okay, so the dose was taken after the meal, and maybe they might benefit from changing the type of insulin altogether if it wasn't rapid acting insulin. So here, I would like to clarify that they took two doses of insulin. One was for the food, the second one as a correction. So first of all, we can see clearly that most likely the carb counting was not done correctly. The second thing is that maybe there wasn't a long period of time of waiting, so it wasn't 10 to 15 minutes. And then we had the hyperglycemia, and then they corrected, maybe it wasn't calculated, the correction, so they didn't get a good result from this. Yeah. So they didn't they didn't count their carbs correctly, and also there's a lot of stacking insulin, and the correction might be incorrect. So here it can be two things. I would like to point out that if the rise is slow, it is normally either a basal problem or a high fat, high protein, so slow digestion. Since this is happening at night, most likely it is a basal insulin change situation. Perfect. So now we move on. So for this one, also I believe that it is a basal insulin problem, since it is dropping slowly. But when it was in the dinner time, it was actually very good values. And here it can be, as we said, also basal insulin, and maybe for some people, consumption of alcohol or excessive physical activity, which can increase insulin sensitivity, or alcohol, which can inhibit regulatory hormones for glucose and glycogen. So this is a perfect example, and I believe each one of us will see a patient with this type of issue, which is the dawn phenomena. One good way to combat this is by having basal insulin taken a bit later at night. So if it was taken at 10 p.m., it can be taken at 12. Another one is to have dairy product at night, which is proven to help with this kind of situations, or to avoid all of it, be on a pump and have more insulin around this phase. So now let's look at some reports. Perfect. So let's discuss the patterns together. For number one, we have glucose levels returning to target within 3 to 4 hours, which is, of course, the mechanism of the insulin itself. And it is matching the carbohydrate intake. For number two, there is a sharp rise and fall in glucose. So this shows us there is a high glycemic index, so maybe a lot of rice, and then the insulin did its job. For number three, we have glucose levels remaining elevated 3 to 4 hours after eating. So it can be many things. It can be a low insulin dose, or just continuous snacking throughout the day. And then for number four, we have hypo within 4 hours of meal. So it can be miscalculation of insulin, it can be overcorrection, or it can be physical activity, which increase the insulin sensitivity, which of course needs to be changed. For number five, we have sharp rise following a hypoglycemia. So this is overcorrection of hypo. And then for number six, consistently elevated glucose levels. So maybe the person is afraid of hypoglycemia or missing insulin doses, so that plays a role, or irregular drops in glucose levels overnight. We see this most commonly with physical activity and sometimes with alcohol consuming patients. So here are some tips that I believe, should be discussed with all of our patients. Insulin timing is very crucial. They should know how to time their insulin and how to time their correction insulin, and just how much, what's the time is for the peak, and when it starts working, and so on. The types of carbohydrates and how to count carbs, snacking between meals. Hypoglycemia treatment should be done, so it should be 15 to 20 grams. We should not overcorrect because we will need to correct with insulin again, and it's a continuous loop. Sometimes people miss or delay insulin, and that creates bigger problems. So, of course, we need to encourage them to be more consistent and accurate with their insulin. Lipohypertrophy is basically a very common problem for people who had a long diagnosis of type 2 and even, of course, type 1. So this is where the fat builds up under the skin, and basically the insulin doesn't reach the tissues, so people can start to have very high glucose levels. And then glucose variability, it really depends on many factors, such as the activity of the person, how much they snack, their hormones, their stress hormones. Are they sleeping? Are they overthinking? And such. And of course, we want to encourage the right tools, such as CGM, such as insulin pumps, for patients who can use insulin pumps. Good resources such as Carbs and Cals, and as I mentioned, Nutrition IX, the Track app, and there are a lot of good regional apps that maybe I can share at the end, or it can be emailed to everyone. So the time and range is actually, to me, it's one of the best tools that we can use with our patients to encourage them to have better values. So it's almost like a challenge with our patients. So basically, we have the time and range. This is the range that we want. This is where there is less danger and less risk of complications. Time above range is where we have all the hyperglycemia complications. And time below range, of course, is dangerous at that same exact moment. And the lower we go, the more dangerous it gets, and people can get hospitalized. So it must be taken very seriously. So for timer, yeah, as we discussed, if we can continue with the PowerPoint. Perfect. So the more time in range we have, the lesser the HbA1c. So as we all know, HbA1c is the average glucose in the last 2 to 3 months. It's also worthy to mention that estimated A1c is also a usable value, and we take that from the sensor itself. For each 10% increase in time and range, we can lower the HbA1c by 0.8% for both type 1 and type 2. And for every 5% increase in time and range, there is a very clear impact on the glucose control and the glucose levels. By spending more time in range, we can reduce the long-term health complications, especially if we have less glucose variability. And the guidelines is having at least 70% time in range. And for advanced type 1 or type 2 patients, we normally want higher than 75. So now let's talk about a case study. So our patient is actually type 1. Her name is Maria. She is 39 years old, and the duration of her diabetes is 15 years. Her BMI is 26, so she is at the start of being overweight. The last HbA1c value is 7.9%, so it is on the higher end. The target glucose, of course, is 3.9 up to 10 millimole. Her treatment is Tresiba 8 units and Fiasp pre-meals with varying doses depending on the diet itself. She has a very strong sense of fear of hypoglycemia. She had severe hypo in the past, so it started a lot of fear, and she started liking being in the higher range to feel safe and away from hypoglycemia. She was recently commenced on Freestyle Libre sensors and prefers, of course, to run glucose levels very high. So now our objective is to reduce her hyperglycemia. Step one, let's validate the data. Let's look at what she's doing right and what's working for her and what's not working. Let's look for hypoglycemia and when it's happening. Same thing with hyperglycemia. We want to identify the patterns. And then let's look for glucose variability, as we discussed, where we have spikes up and down. So this is basically what we're looking for. First, when you open an AGP report, this is what you're greeted with. We have the time and range as we discussed. So this is a very good tool. We have the target range. It is 44%, which is way below the target 70%. She stopped having hypoglycemia, which is excellent. We don't want hypoglycemia. But her high values and very high values reach up to 56%, which is not preferred. It is also worthy to mention that the target for low values should be less than 4%, and the preferred, of course, is less than 1%. And for high values, it should be less than 25. So she is double what we actually aim for. The average glucose is 10.7, and the glucose variability is 26, which tells me that it's not really going up and down throughout the whole day, but it's always staying in the higher range, which is not what we want. So as you can see here, there is almost no values for that reach 5 or 4 or even 6. It's almost all 7 and higher, with most of the readings, as you can see in the dark blue, it's around the 10 up to 12, which makes sense why the average is 10.8 or 9. So here is one of my favorite features in the AGP report. With the daily glucose profiles, we see the full week, and actually in 2 weeks, I mean, and you can see how days blend in with each other. You can see how the decisions at night are affecting the values at midnight or in the morning, and we can see a continuous pattern throughout the whole week instead of throughout the day. So here we can see there are a lot of hypers on the second line, and then on the first line it's less hypers. This can indicate that there is some changes to her treatment plan, or maybe stress levels, or maybe injection sites. So it can be many things that we can check with her personally. So like we said, the daily logs can tell us that there are changes, that's how the food is changing, that there are changes in physical activity. Maybe they got sick, or they're stressed, or with our female patients, sometimes before the period or within the period itself, they have higher glucose readings or more insulin resistance. Insulin timing can be seen on the graphs, and of course with the treatment maybe they have hypertrophy, maybe there is mismatch or bad carb counting, and maybe they're not correcting their insulin. Maybe they're guessing the correction, which is something that is very common that we see with our patients. Okay, so let's look at her graphs. Let's start at the left corner at the top, starting from 12 or 0 up to 6 a.m. So from midnight to morning. We can see that her starting RBS levels was around 8, so it was 9, and then, I'm sorry, around 10, so 9, and then 10, and then dropping, slightly dropping, and then going higher. And then with the basal insulin, we can see a very slow drop. And then in the morning, she didn't log in any food. Maybe she ate something light, or maybe she avoided food completely. And then the basal insulin weared off. And then with the stress of work and being, working quickly and everything being hectic, she started having higher glucose levels because there is no insulin that is active in the body. And then later on, we see that she had fast food. She had fries and a burger. And most likely she didn't divide her doses. So she had hypo. And then when the food started digesting, it started going up and up and up. And then later on, many hours later, it started to slowly go down. The other meal was also rice and meat. So one thing I would change here, a very common mistake, is that they need to correct the insulin and stack it with insulin for the food. She's not doing that. She's comfortable with 10 and 9 and 8 and 11, and that's keeping her within that range. On the second day, we see also the starting point is very high. She took some insulin, and then the correction was 2 units. 2 units was not enough to make her drop from 18 up to, let's say, 7 or 6. So it dropped her only to around 15. And then after that, the basal insulin was working, and it slowly took the glucose down up until the ranges that she is comfortable with, which is 8. And then she had 1 slice of toast. She took 2 units of insulin. She had a small rise in glucose because 1 slice of toast is low in carbs, and then it slowly dropped. Later on, she had a lot of food altogether, and which was a lot of cheese, and then 2 toasts, 1 banana, peach and yogurt, and she took around 8 units. And there was it covered the rise, but like we said, her RBS levels before eating is not what we prefer. I think she needs more correction insulin stacked with her meals as long as her readings are higher than 8 before eating. Here is another day. This one is much better. From the starting point, it's already below 10. It's around the 8 range. And the basal did its work where it dropped closer to 5. We're still not in hypo. And then slowly it went up and then stayed neutral around 7 or 8. And then slowly, as the basal insulin was wearing off, the RBS went up. She had a biscuit, and she didn't take any insulin. And then she had a small rise, and then the RBS went down. She had a satsuma, which I believe is a type of orange. And she had 1 slice of toast, and she had a 30-minute walk and 1 unit of insulin. 1 unit is, of course, not enough to cover all that was eaten, but the 30-minute walk did a lot of work in controlling the RBS in a good way. Moving on to the later part of the day, she had beef stew with dumplings, banana and yogurt, and she had 8 units. I believe also for this one, the 8 units is a mismatch because the 8 units was intended for the food and not as a correction. But it worked in the favor of the patient, where it dropped the glucose to a better range. And then later on, it started going up. The last day, I believe, it's similar. The patient is comfortable with those readings and they need more basal and more correction. Most likely, most of the time, they need to take their insulin a bit earlier and stack it with correction. Okay. For this slide, we can see a similar pattern, but I believe there is less variability. So this is what is bothering me with this patient, because she's always at night, it's always high, and the basal is doing the lowering instead of correction. We can aim for, with correction, we can aim for a value of 8 or 7, and then the basal can drop the sugar levels up to 5 or 4, which is still not hypo, instead of having this. With the carb counting, I believe that overall the carb counting is fine. Sometimes it's working, sometimes it's not. But again, correction dose. And then at the end of the day, there was a lost sensor connection. So of course, if the patient scanned the sensor, they would regain the readings, it would complete. But we can see the pattern clearly, where it's still going very high up to the 20s and then going down. So I'm seeing the problem very clearly, and it's very repetitive. So now moving on to the last slide. So for the last slide, we would like to remind everyone that Freestyle Libre is easy to apply. It's very comfortable. I use it personally, and I use it with a lot of my patients. I genuinely believe in this product, and I recommend it to all of our type 1 and type 2 patients. And that's it. Thank you for your time.
Thank you so much, Khaled, for the insightful presentation and sharing your experience with us. And now we will move on to the Q&A section. Please continue posting your question in the chat, and we will go through as much as possible. So here we have a question. They're asking, what about carb counting? Can you give basics?
Perfect, yes. So for carb counting, I would like to simplify it in this way, okay? Carb counting, what we need to be accurate is to have the amount of carbs in weight. So we either can calculate the weight, or we can buy something that was pre-calculated by the company. So on the package, it can say this is 100 grams, 50 grams of rice, pasta, or of this sandwich, like in the size. And by having that, we can just use many different resources, as I mentioned earlier. We have ChatGPT, which can be accurate if we are accurate with the weight of the food, or we can use more, let's call it more professional methods, such as the Track app, which is, I highly recommend it. Inshallah, we will send it to everyone, the names. We will have the Nutrition IX, which is a website with a database. You can input the weight of the food, and it would give you the carbs exactly as if it has a nutrition label. There are many other methods. To simplify things, we can use a measuring cup. We can count with a spoon. We can count with an empty mug, a coffee mug. And all these methods can make it a lot easier for us and our patients to implement our counting. So weight and database. And this is
Great.
overly simplified.
Yeah. And here we have another question. How to manage patient who's taking mixed insulin, having hyper after food and hypo in the morning?
So it would be easier for me to answer if I know which kind of insulin exactly.
Yeah, it's mentioned Risodeg.
Okay, okay. So with mixed, of course, we have a slower insulin. So it can be taken like a longer time before the meal. So it really depends on the treating doctor and what they recommend because they know the RBS values, they know what's happening and when they're having the hyper. So they can compare maybe on the ATP report, when are they having the hyper, and they can time the insulin based on the time of the hyper. So there isn't really a correct answer, but it's definitely it definitely needs more time than Novorapid and Humalog. It can be at least 20 minutes more in waiting before the food. Or we
Great.
can make a small change. I just want to add one point. We can make a small change, which is make the food a lot slower digestion. So more fiber, more healthy fats, more protein, instead of having food that is mainly carbs. And that should give insulin more time to work.
Amazing. Coming to the third question, I really appreciate the behavioral model and strategies you mentioned. And I agree that patient engagement enhances motivation and support positive behavioral changes. However, some patients, especially teenagers, tend to hide things and dislikes feelings exposed. What would you suggest as an approach to encourage these individuals to use CGM?
Okay, this question actually made me smile because I personally was one of those people. I used to lie with my RBS values and I completed the diet recall and all these details. And because I did this thing and now pharma is giving me patients that do this to me, I understood some things. So first of all, we don't want to be judgmental, especially with these patients. We want to make it very clear that we are on their side, and if they are accurate with their what they're telling us and the values, then we will help them. It is very clear, very easy for the patient to see the healthcare professional as someone who, of course, has information, but not necessarily on their side fully. You know, they must feel like they are understood. So first of all, understood. Second, they should feel supported and that this step will support their journey. Third, to use CGM because this is a separate part. The most excuses I hear with my patients, the ones I try to encourage, is that they are annoyed by the alarm. So I tell them that there are alternatives and you can control the volume and so on. The second one is by my female patients, especially the ones that are younger than 21. I hear from them that they don't want to go to, let's say, weddings or gatherings and have the sensor be clear to the people in the gathering. So for this, I tell them that they can cover it. They can remove it on the day of the occasion and use the glucometer. If this is necessary, of course, we don't want to always remove it. And of course, always try to understand the patient and go with what's comfortable for them as much as we can. We don't want to push it. I hope that
Another question from Dr. Muhammad. Yeah, thank you for a beautiful lecture. Usually, all foodstuff are labeled as carbohydrate, for example, 72 grams over 100 grams. How to calculate the actual sugar in that? About the food labeling.
Yeah, so normally we can, for this, we have two answers, okay? There are some companies that, when, let's say, a chocolate bar, okay? So a chocolate, sometimes with chocolate, we see that they give us the carbohydrates directly. So it says for the 2 fingers of chocolate, you're getting, let's say, 35 grams of carbs. So if it's indicating that it's 2 fingers and there are only 2 fingers and we're eating 2 fingers, then we don't have to do any calculations. It is the number that is labeled. But the confusing part, the one that you are asking about, is when the serving size is different than the net size, the size of the package itself. So the way we normally do it is that, or the way I do it personally, is I call it the bigger number, which is the net size, the size of the package. Let's say it's 150 grams. And then I take the serving size, which is the smaller number, and we divide them. So the big number divided by the small number. We get a ratio. Let's say it's 2.2. This ratio, we multiply it with the carbs, we get the total carbs. So this is normally the calculation we use. There are a lot of examples online, but if my explanation is not clear, you can ask me more on what's not clear.
Great. I don't see any more questions in the chat. If you have any more, please post them. And we would like to also, on behalf of the organization team, I would like to thank Khaled for his valuable insights and all of you joining us today. Thank you everyone for your active participation and your thoughtful question. We will have a link for the feedback. Please scan the QR code and share with us your feedback about this session. Thank you, everyone.
Thank you, everyone. It's lovely to talk to each one of you. I appreciate all the support. I hope you learned something today.